Hi friends, this is Dr. Kadam Nagpal, Senior Consultant Neurologist from PSRI Hospital. So today I shall be talking about multiple sclerosis. There have been lots and lots of myths about this particular disease and very less information is being available for common people awareness and their understanding. So multiple sclerosis is an immune mediated process where the damage occurs at the level of nerve cell, and there is a nerve cell covering what we call it as myelin, and the myelin results in proper conduction of the nerve cell and transmission of proper impulse. So what happens that this immune mediated damage occurs at the level of myelin, and this process is what we call it as demyelination. So whenever the myelin is attacked upon, the myelin of the nerve cell gets destroyed and demyelination occurs. So demyelination usually can involve the central nervous system, where usually the patients might come up with visual complaints like loss of vision, double vision, or they might be having some kind of demyelinating focus or demyelinating disease inside their brain, and accordingly whichever pathways or whichever circuitry in the brain gets involved, they manifest with that particular symptoms. They might be having demyelination in their spinal cord, which might result in similar sort of manifestations. So patients often complain of visual disturbances, double vision, numbness or weakness on one side of the body, numbness in the legs, urinary and bladder symptoms, and difficulty in maintaining proper balance. Patients are usually of multiple sclerosis in their younger age group. Most common affliction happens in between 20 to 40 years of age. There is a subcategory, what we call it as pediatric multiple sclerosis, where children get afflicted earlier in their age groups. Very few patients develop multiple sclerosis beyond 50 years of age. So predominantly the age group what we see with this particular ailment is between 20 to 50 years of age. So as mentioned, demyelination targets the optic nerve or the visual pathways, the brain and the spinal cord. So accordingly the manifestations of the disease happens. There is no particular causative feature which might be resulting in multiple sclerosis, but there is a genetic predisposition. Genetic predisposition does not imply that the disease has got a genetic mutation of some kind, but yes, there are certain people who are more predisposed on having this particular ailment. Initially, this ailment was being often seen in the Western context where there was lack of sunlight. So vitamin D3 deficiency also is a risk factor. Accordingly, there are propositions that some infections might be resulting in multiple sclerosis. That what happens that whenever the infection gets the patients harbor any kind of infection, the infection trigger an immune mediated response which result in further demyelination. So the categorization of the patient is very important, that which type of multiple sclerosis pattern the patient is being following, and whether the patient is being having multiple sclerosis, and what are the chances of him having relapses or recurrences in future. So there is a very detailed process of evaluation what we often do. We put them in a clinical criteria and categorize their ailment accordingly, and accordingly the patients are being started on these medications. So to start with, we often give steroids in different doses to have any kind of betterment in their acute relapse, and we categorize whether these patients fall into the category of further future relapses. Then disease modifying therapy is being started as per the patient profile. So accordingly we make a collective decision making with the patient when we start with disease modifying therapy. Earlier institution and administration of disease modifying therapy results in lesser disability and lesser chances of mortality and death because of this particular ailment, because eventually if this particular disease is not treated early, patients will be disabled, patients will be wheelchair bound, eventually they will be bed bound, and many other complications might affect, and infections and bed sores, and these are the common ailments which trigger once the patients are bed bound and severely disabled in this particular ailment. So early treatment administration is very important, and with early institution of therapy we see that patients might be might be conducting their normal life, normal lifestyle, normal activities of daily living like a routine person, and they would be completely cannot be differentiated amongst with a normal patient many a times as well. So there are many patients who often continue and adhere to the treatment. The problem occurs when patients often have some kind of a false belief that it's just a minor problem and they might just like overcome with this, and they might not be the patients who would be taking disease modifying therapy for their entire life. When they don't adhere to the treatment, further future relapses and recurrences and eventually the lesion load in the brain make them more disabled, and eventually they become wheelchair bound and bed bound. So early diagnosis, early institution of treatment and further adherence of the treatment with further future follow-ups with their neurologist is very important to maintain the patients without any future disability. Thank you.